Hello, and welcome to this talk from the Yale Child Study Center Program for Anxiety Disorders. I'm Eli Leibowitz, and in this talk, we'll discuss the most active ingredient in the treatment of childhood and adolescent anxiety disorders: exposures and desensitization. By this, we refer to the process of gradually bringing a child into direct contact with the stimuli and the situations that provoke their fear and that they've previously been avoiding. We'll take a look at some keys to successfully implementing exposures and overcoming some of the obstacles to this treatment. The basic principle of desensitization is easily grasped and in fact already familiar to almost all children from a young age. Every child knows that things get easier as you do them over and over again, and that repetition dulls the emotional impact of almost any experience. For example, a frightening movie is most scary the first time you watch it. But a child knows that if they were to watch the same movie over and over and over again, it would turn from an exciting experience into a rather boring one. To explain to a child how the same principle holds for exposures in the context of cognitive behavioral therapy and how it can be applied to helping them overcome their anxiety disorder, we can make use of the wave model of anxiety. In this model, the vertical axis represents anxiety or discomfort, and the x-axis represents time. Ask a child to imagine someone with a fear, perhaps a fear of heights, who approaches a balcony and looks out over a high edge. They're likely to experience more and more anxiety, as represented here by the rising curve of the black line. As they grow more uncomfortable, perhaps their heart racing or becoming dizzy and their mind filling with scary images of themselves falling, they're likely to draw back from the edge in what we term avoidance. This can lead to a sense of relief and a rapid reduction in anxiety. Although they'll feel better at that point, as represented here by the blue line of avoidance, they won't be any closer to overcoming their anxiety disorder. In fact, next time they approach the edge, they'll feel just as scared, if not even more frightened. But ask a child to imagine what would happen if that individual were to stay looking over the edge and not draw back, even though they felt really uncomfortable. Their anxiety, which was on the rise, would probably continue to go up until it peaked at some maximum level. This is a good point at which to remind child and parents that although they would be extremely uncomfortable, they wouldn't be in any risk from that anxiety. Nothing catastrophic would happen. They wouldn't die or faint or lose their mind. They'd just be really uncomfortable. And if they continued to stay there for a few minutes, perhaps 10 or 15 minutes, their anxiety would probably start to go down. And after a while, maybe half an hour, they'd find themselves quite calm, even though they were still looking over the edge. Their brain would just have had enough time to process the information that nothing terrible is happening. Of course, this would be much harder to do than the quick avoidance and its rapid sense of relief. However, by repeating that exercise a few times, they would gradually be able to approach the edge without their anxiety actually going up all that much. And if they practiced this enough, they would soon overcome their fear of heights. This is the principle and the way it's applied in cognitive behavioral therapy. There are any number of ways to perform exposures in CBT, but there are some characteristics of most successful exposure plans, and together these constitute useful guidelines for planning and executing exposures in treatment. A successful plan will usually ensure that exposures will be gradual, repeated, and prolonged. Gradual exposure is important so as to allow the child to only experience a limited amount of anxiety at each step in the process. This is a little bit like climbing a ladder, where someone might eventually climb to great height, but only ever has to raise their foot about 1 foot high up in the air. In order to ensure a gradual process that's well suited to a specific child's reaction, the patient and therapist work together to create an exposure hierarchy. It's important that the first steps on the hierarchy be quite easy and well below the child's maximum tolerance level for anxiety. This is important both to ensure success in this early stages of the game in order to maintain a child's motivation. It's also important to allow the child that there's still room to make progress and proceed after the initial exposures have been completed. A child who undertakes a tremendously difficult exposure right away might withstand that experience, but could come away from it feeling like they can't go any further forward. On the other hand, a child who undertakes only a moderately difficult exposure could come away feeling strengthened and eager to continue the process. It's useful to ask a child to rate how difficult each step on the exposure hierarchy seems to them, perhaps on a scale of 1 to 10 or 1 to 100. But it's important to keep in mind that those ratings, although they're useful for creating the correct sequence of exposures, are only guesses and don't accurately predict how much fear a child will actually experience. In fact, when anxious, most children will rate almost all steps on the hierarchy as more difficult than they'll actually turn out to be. This is in large part because through the process of continued avoidance and generalization of that avoidance, the child has come to think of many things as difficult when, in fact, if they were doing them, they would see that they're not. But it's never useful to try to convince a child that something will be easier than they think. This will only feel to them as if we're belittling their accomplishment. Rather, this is a good opportunity for a child to learn that anxiety cheats them by making things seem more difficult than they actually are, and for the child to experience that they can actually undertake and withstand challenges that seem really difficult at first. Here's an example of an exposure hierarchy taken from a child with separation anxiety disorder. As you can see, the first steps on the hierarchy are really easy. Maybe just a minute in which the parents are in another room, and then maybe a minute with the door closed and the parents in another room. And only after quite a few steps are taken does the child begin to undertake exposures of a greater difficulty, such as the parents actually leaving the home for a while. In this example, which is part of the exposure hierarchy from a child with obsessive-compulsive disorder, you can see that the steps on the hierarchy include both exposures to real-life situations and exposures to the kinds of thoughts that make up such an important facet of symptoms in obsessive-compulsive disorder. A second important element in successful exposure treatment is that of repetition. It's almost always a mistake to complete an exposure just once and then to move ahead to the next step on the hierarchy. Rather, each step should be performed multiple times, and this is to ensure that the child is not only able to withstand the anxiety of a given step on the hierarchy, but that we've actually turned that event from an anxiety-provoking situation into a kind of non-event that signals true desensitization. And so before moving ahead to the next step, the child should be able to rate the previous step as being either very easy or at least much, much easier than it was before they started the process. The third element of successful exposure treatment is that of duration. Ideally, each exposure will allow time for the child's anxiety to rise, peak, and then subside before any avoidance is undertaken. This will usually take somewhere between 15 and 20 minutes, with the maximum anxiety occurring pretty early in the process. However, very often children will be unwilling to undertake such a long exposure at the beginning of the process. For example, a child with fear of darkness might be unwilling to spend 15 or 20 minutes even in a semi-darkened room. When this is the case, it's a mistake to rigidly insist on correct exposures of 20 minutes. And rather, the child should be encouraged to do a shorter exposure, sometimes even less than a minute long, in order to allow them to overcome that, to see that the anxiety isn't as difficult as they thought it would be, and then to gradually increase the amounts of time. Even though these brief exposures might be theoretically ineffective, they're actually a tremendously important part of the process, allowing the child to ally themselves with the therapist and to begin undertaking exposures to the kinds of situations that they previously have been avoiding. Sometimes the initial exposures will be so brief or easy that they'll represent things that the child might have been doing spontaneously anyway in day-to-day life. And yet, by defining them as an exposure and asking the child to actively engage in them as a way of overcoming anxiety, an important step is being taken. One special kind of exposure is exposure to thoughts and imagination rather than to real-life situations. These imaginary exposures are useful in two different kinds of situations. One use of imaginary exposure is as a kind of preliminary step to real-life exposure. For example, a child with social anxiety disorder who is planning to undertake a step such as speaking to a stranger on the street might find that too difficult to do right away and could benefit from imaginary exposure, in which the therapist will guide the child through a kind of imagined scenario of speaking to a stranger on the street and allowing their anxiety to rise in a moderate fashion at that imagination and then to subside. And as the child becomes desensitized to the idea of speaking to a stranger, they may find themselves more willing to undertake the actual exposure afterward. Another situation in which imaginary exposures can be very helpful are where what the child is avoiding are actually thoughts rather than real-life situations. This is often the case in obsessive-compulsive disorder, in which children try to avoid intrusive thoughts that cause them distress, and it can also be the case in generalized anxiety disorder, in which children try to avoid the persistent worries that intrude onto their mind. One helpful way of engaging in imaginary exposure is by creating a kind of script or scenario which could be recorded, and then the child could listen to it multiple times over the course of the week, or perhaps by writing it in story form and having the child read it over and over again. In one example, a young man with obsessive-compulsive disorder who had a fear of losing the key to his home because he imagined a burglar finding it and breaking in and hurting his family, felt compelled to engage in prolonged rituals of searching for the key to his house whenever he left a room, sometimes for up to 20 minutes at a time, even though the key might have been safely in his pocket. That young man created a kind of personal horror story, describing how because he stopped doing the ritual, he actually did lose his key, and a mean burglar found it and broke into the home and hurt his family and kidnapped him. And although that's a horrible story to listen to the first time, after he listened to it for about half an hour a day over the course of a week or 2 weeks, he became quite desensitized to the thought, so that he found himself rather bored by it, and his urge to engage in the compulsive rituals was quite dramatically reduced. And so, over the course of cognitive behavioral therapy for anxiety disorders, children will usually work through a program of gradual, repeated, and prolonged exposures, bringing them into contact with the situations that they previously feared and allowing them to become accustomed to them and to deassociate those stimuli from the anxious response. Thank you.